Good afternoon, everyone. Please, can you just confirm you can all hear me clearly? You can just type one if you can hear me, just to be sure we are good with sound. Okay, great, 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 great. Thank you very much. So I want to start right on time. Um, it's a pleasure to have all of you here this beautiful afternoon. It's my hope that this will be a very engaging session. Okay, so by way of starting, I would like to greet again, say good afternoon to everyone. It's a pleasure to welcome you to this SYNLAB quarterly webinar, and it's a conversation that would not be more timely or relevant. Today we'll be tackling a fundamental challenge in healthcare, which deals with expanding access to convenient care. Healthcare access is more than just a policy issue, frankly. It's a pressing reality for millions of Nigerians, millions of people around the world, but we'll be zoning in on Nigeria in this particular webinar. According to the WHO, at least half of the world's population lacks access to essential healthcare services. In our continent, Africa alone, over 80% of the population relies on out-of-pocket payments for healthcare. This evidently makes affordability a major barrier to accessing care. In Nigeria, the case is actually even more stringent because the doctor-to-patient ratios currently stands at about 4 per 10,000 people. And this is even further compounded by the whole Japa syndrome. The gap between demand and accessibility obviously continues to widen, and this is a big problem that we have in the country. However, in recent times, we started seeing some gradual improvements, and it tells us that perhaps there is really light at the end of the tunnel. There's been some good news. Innovation is beginning to change the landscape. We're beginning to see a rapid adoption of telemedicine. Howbeit, the impact is not yet as great, but again, it's something we're beginning to see. Digital health solutions are beginning to spring up. We're beginning to see decentralized healthcare models, which has proven that care can be more accessible, affordable, and efficient. Yes, all of those things have not really scaled as much as we want them, but we're beginning to see elements of them pop up here and there. From mobile health platforms to AI-driven diagnostics, technology is beginning to bridge the gap that once seemed insurmountable. However, innovation is not enough. Like I usually say to my tech friends who build tech platforms, I said, the technology is an enabler and may not really solve all the problems because there are still fundamental infrastructural issues that needs to be sorted. However, policy frameworks and strategic investments are critical in ensuring these solutions become scalable and sustainable. This is why today's conversation is so important, very important. And we are joined by a panel of visionary leaders, industry experts, and policy influencers who will share their insights on how we can drive real change. Like from someone I respect a lot once, I said, oftentimes the change you want can only be driven one conversation at a time, and the conversations spur actions that would then lead to the tangible changes that you intend to see. So we hope that this conversation, which we're starting today, will spur something within several circles, both in the policymakers, private sector, and in the active public sector. So as we begin, I encourage you to think about certain questions, 3 key questions. 1, how can we ensure equitable access to quality healthcare, regardless of socioeconomic status? What policy shifts are needed to accelerate healthcare innovation in Nigeria and beyond? And lastly, how can the private sector and the public health institutions collaborate to create sustainable healthcare solutions? With that, I would say let's dive right in, and please join me in welcoming our esteemed speakers. We have Dr. Ola Brown, a leading voice in health investment and fintech, driving innovation through HealthCap Africa. We have Dr. Adeniyi. He's a public health expert in WHO at WHO Nigeria, who is shaping disease surveillance and response strategies. We have Dr. Bisola Adebayo, who is a renowned public health physician and epidemiologist, driving impactful policies and research. And of course, leading to this discussion or hosting today's discussion is my humble self, Kenneth Okolie. I lead a diverse team of excellent individuals at SYNLAB Nigeria, and I serve as its CEO. Having said that, I would say, why don't we get right started? And to start off the conversation this afternoon, we'll be starting by hearing from Dr. Adeniyi Ayobami. Before I give him the platform to proceed, I would just like to give us a brief bio, an abridged bio of himself, just so that we can better appreciate the resource person we have today. Dr. Adeniyi Ayobami is a public health expert with extensive experience in disease surveillance, epidemiology, and health policy. He is currently a national professional officer surveillance at WHO and has previously served as a COVID-19 response coordinator and tuberculosis surveillance officer at WHO. He has a PhD in public health and an MPH in health policy and management, and of course, an MBBS. Dr. Adeniran is a fellow of the Royal Society of Public Health and a member of several international public health organizations. His research focuses on infectious disease surveillance, TB case detection, HIV/AIDS, and health system strengthening, with multiple publications to his name. He is a passionate advocate for good health, for global health and innovative interventions, and he remains committed to improving health outcomes in Nigeria and beyond. Please join me in welcoming Dr. Adeniran Adeniyi Ayobami. Thank you very much. Sir, you may please carry on. Are you muted, sir? The floor is yours. All right. Okay.
Okay. Hello. Good afternoon. Kindly confirm I'm audible.
You're very audible, sir.
Okay. Thank you. All right. Thank you. Good afternoon, everyone. Good afternoon, CEO, Dr. Kenneth.
Good
Thank you
afternoon,
for
sir.
that short part.
No problem.
My name is Adeniyi Ayobami, as I've been introduced. I'm a public health physician and an epidemiologist. I've worked in a number of organizations where I provided strategic and technical support in areas of disease surveillance, disease control, policy and guideline development, capacity building, PhD revitalization, healthcare financing, and financial risk protection. As earlier mentioned, I work with the World Health Organization as the National Professional Officer for Surveillance and Integrated Service Delivery. Okay, we almost likely have seen at one point in time in our lives the devastating consequences of lack of access to healthcare. And this is why I'm excited this afternoon to share my thoughts with you on somewhat a broader and relatively new concept, access to convenient care. As much as we'll be looking at policy today, just like the CEO mentioned, I want us to remember that access to convenient care isn't just a policy issue. It's not about policy alone. It's a human issue. It's about us. It's about our friends. It's about our family. It's about our neighbors who struggle every day to access the care they need in different parts of the country. So in the next few minutes, I'll be discussing policy solutions as a foundation for expanding convenient care. Although presently the World Health Organization has not provided a definition for convenient care, but convenient care refers to a type of healthcare service that provides treatment for illnesses and injuries, usually minor ones, and are typically located in easily accessible places like pharmacies and standalone laboratories. And they offer quick access without needing very formal appointments. It's essentially a readily available option for non-life-threatening medical conditions. In the WHO, the closest concepts that have been defined that are close to convenient care are things like quality care, people-centered care, and universal health coverage. Like convenient care, these concepts describe timely and equitable care that reduces waiting times and harmful delays. It is such a care that doesn't vary in quality based on gender, ethnicity, or religious beliefs. It's a type of care which puts the needs of people and communities at the center of health systems. Convenient care model has also been documented to build long-term relationships between the patients, providers, and the health systems. It's a model of care that is respectful and responsive to the needs of people at hours, places, time, and locations that suits the patients. And expanding access to convenient care also underpins the achievement of universal health coverage of the World Health Organization, which describes an ideal situation where all people have access to a full range of quality health services that they need, when they need it, and where they need them, without financial hardship. So it will interest you to know that currently the world is off track to make significant progress towards universal health coverage. Improvements to health services coverage have stagnated since 2015, and the proportion of the population that faced catastrophic levels of out-of-pocket health expenditure has increased continuously since the year 2000. This global pattern is consistent across all WHO regions and in most countries. It is also no news to us that the COVID-19 pandemic has further disrupted essential services in a large proportion of countries at the height of the pandemic in 2021. Changes in population dynamics globally and nationally, such as population growth, increase in aging population, increase in rural-urban migration, has also created the urgent need to begin to look at innovative strategies towards expanding access to care. With the persistent brain drain in the health workforce, as earlier mentioned by Dr. Kenneth, dwindling resources, inequity in available health workforce distribution, increase in inaccessible settlements as a result of insecurity, wars, criminal activities, and climate change, the emergence of antimicrobial resistance, and the re-emerging infectious diseases like mpox and diphtheria, there have to be discussions around innovations in expanding access to care. And for the purpose of emphasis, innovations around access to convenient care. The expansion and long-term success of convenient care model, and by expansion, attainment of quality care and universal health coverage, will only be driven by sound policy frameworks and a deliberate push for policy implementation. Health policy, according to the World Health Organization, involves the decisions, the plans, the actions, and sometimes inactions taken to achieve specific healthcare goals within a society. Health policies can include legislative and regulatory efforts, organization, financing, and delivery of healthcare services, as well as guideline development for government actions. Now, telehealth, a key component of the convenient care model, provides access not only to patients, but also to rural facilities to access primary and specialty care. Telehealth has been considered to be cost-effective when compared to the more traditional face-to-face way of providing medical care. Nigeria commenced the use of telemedicine in 2007 or thereabouts, and it has grown due to increased internet penetration in the country. It also grew as a result of the COVID-19 pandemic, also due to shortage of healthcare professionals in the country. Telemedicine is expected to continue to grow and improve healthcare in Nigeria, as currently there is willingness to adopt telemedicine due to inadequate resources and increase in hard-to-reach areas. We're having an increase in hard-to-reach population as a result of civil unrest everywhere, insecurity, and climate change like flooding in different parts of the country. So telemedicine, as it is practiced in Nigeria, is a subset of telehealth, with the use of technology to remotely provide healthcare services. It's a growing field that can help improve access to healthcare, especially in our rural areas. It's also a viable tool that can be used to support private health facilities in remote or rural areas, in areas of clinical and laboratory diagnostics, in medicine supplies, electronic medical records, and in assessing clinical second opinion by these primary healthcare facilities located in remote areas. Personally, as a primary care physician, I'm bold to say that telehealth has significantly improved access to healthcare in many parts of Nigeria. The use of technology tools such as the popular one, probably the most popular in Nigeria currently, the WhatsApp, instant messaging platform like WhatsApp, emails, teleconferencing, and video conferencing has significantly increased following the COVID-19 pandemic. This has reduced waiting times, improved diagnostic accuracy, and treatment plans. It has reduced the need for referrals, improved patient prognosis, and ultimately, it has improved patients' outcomes. Challenges to implementation in Nigeria, however, due to lack of access to electronic records, collection of incorrect, inconsistent, and unreliable data from patients, data security and confidentiality, inadequate telehealth infrastructure, including poor internet connectivity in rural areas, and unstable electricity supply. These are some of the challenges faced by telehealth practitioners in Nigeria. The convenient care model, however, unexpectedly has generated multiple concerns about legal liabilities, scope of practice, scope of service, technological infrastructure, and human resources. There are so many concerns around this area. The adoption of telemedicine services in Nigeria will require the development of legal and policy framework. Presently, there is no substantive law regulating the operation of telemedicine in Nigeria. This, however, does not leave the telehealth medicine in Nigeria unregulated. Priority areas of regulation and policy developments that we'll be discussing this afternoon are the issues of registration and licensing, telehealth reimbursement, interoperability of portals, interfaces, and data platforms, data privacy and protection and confidentiality, technology transfer, medical and nursing schools curriculum development, research, and development. So quickly, let me talk about registration and licensing in the telehealth sector. Healthcare providers, specifically telehealth care providers, must possess the necessary qualifications, professional licenses, and registrations to provide telehealth services to patients in Nigeria. These registrations and licenses are provided by the Medical and Dental Practitioners Act of 1988, the Nursing and Midwifery Registrations Act of 1979, the Pharmacist Council of Nigeria Establishment Act of 2022, and a few like that. Now, depending on the model of operation, it may also be necessary to obtain certain licenses and registrations from the Federal Ministry of Health and the National Agency for Food and Drugs Administration and Control, NAFDAC. For instance, in Lagos State, health facilities, including telemedicine facilities, are expected to be registered with the Health Facility Monitoring and Accreditation Agency, popularly known as HEFAMA, in pursuant to the Lagos State Health Sector Reform Law of 2006, with the registration renewable annually. Secondly, let's look at company incorporation. One of the requirements for the operation of telehealth, and by expansion, any business in Nigeria, is the incorporation of a local company as required by the Companies and Allied Matters Act of 2020, popularly referred to as CAMA. Thus, to operate a telemedicine business in Nigeria, a local company has to be incorporated with the Corporate Affairs Commission. And in addition to incorporating a local business, a company with foreign participation is also required to be registered with the Nigerian Investment Promotion Commission, NIPC, and also obtain a business permit from the Federal Ministry of Interior. Now on telehealth reimbursements. A major challenge that must be overcome for effective reimbursements is to address the patient's geographical requirements of receiving healthcare via telemedicine. If not properly addressed, telehealth will tilt the health sector into inequity, especially for the rural dwellers, and telemedicine will remain a fringe benefit for urban dwellers or the rich. There might also be need to integrate the billing procedures and patient records with the existing structure in the health system. Telemedicine, let us remember, is just a tool and not a separate health system. Hence, there is need for us to integrate telemedicine into the existing structure in the health system. These services should not only be those required by the urban dwellers or the elites or the rich in the society. Another thing we need to talk about is credentialing. Credentialing is the process whereby we verify a healthcare provider's qualifications, experience, and licensure to ensure they meet the set standards by regulatory bodies. And also, this has to be streamlined to accommodate facilities in rural areas. Because if we have to go by all standards, there are some probably infrastructural deficits in rural areas that health facilities in rural areas might not be able to meet the credentialing requirements. So there must be policy in place, one, to ensure proper credentials of the participants in the telehealth medicine, telehealth business, but also it has to be streamlined in such a way that accommodates healthcare facilities in rural areas. Let's look at data privacy, confidentiality, and interoperability. The Nigerian Constitution of 1999 guarantees and protects the privacy of citizens. And to that extent, the Nigeria Data Protection Act of 2023, NDPA, is the regulatory framework applicable to the collection, processing, and storage of patients' data. This act amplifies the constitutionally guaranteed right to privacy in the Nigerian Constitution of 1999. The NDPA also regulates cross-border transfer of patient data and provides for security measures to be adopted by telemedicine businesses to ensure the security and protection of patients' data. This act also addresses the interoperability of portals, interfaces, and data platforms. Since telemedicine also involves collection of the patient's data and processing of this data and health records, telemedicine providers are also expected to register with the Nigeria Data Protection Commission, NDPC. Let's talk about confidentiality. Patient health information should be obtained and held confidentially by telemedicine providers without disclosing it or allowing access to it by unauthorized third parties as required by the National Health Act of 2014. Concerning interoperability of platforms and data interface, there should be standardization. Standardization is crucial for ensuring that different digital health platforms can communicate seamlessly with one another. As a program person in the country, I can tell you that this is a big challenge in Nigeria. We have so many data platforms for surveillance and epidemiology. We have for TB programs, we have for HIV programs that do not, and the DHIS too, that do not speak or work seamlessly with one another. So Nigeria should implement standardized protocols and interoperability frameworks that encourage IT infrastructure vendors to adopt these standards when providing telehealth solutions. There should be policy framework that sets the standard of data interfaces so that when any vendor comes into the industry, these standards are given to the vendors and it makes the platforms to work seamlessly with one another, and there could be easy flow of data securely across various healthcare platforms. Another policy issue that we should be looking at is the issue of technology transfer. The National Office for Technology Acquisition and Promotion Act of 1979, NOTAP Act, regulates the transfer and acquisition of foreign technology by companies in Nigeria by making the contract and agreement to transfer technology negotiable with NOTAP. Invariably, the transfer of foreign healthcare technology, such as patents, to a telemedicine company would be subject to registration with NOTAP. A quick look at medical and nursing schools curriculum. With the rapid evolvement of telehealth in Nigeria, there would be need for a review of schools curriculum in order to prepare health workers for the new innovations in the health sector. The Nigerian Educational Research and Development Council, NERDC, is an agency of the federal government of Nigeria that is saddled with the responsibility of implementing educational policies in Nigeria. It was formally recognized by law in 1988 by an enabling decree number 53, now Act number 53. Stakeholders engagement. For an effective adoption of utilization of healthcare, of telehealth, it is imperative to identify and engage all stakeholders involved in the telehealth industry. In telehealth, there are three key players that we must consider, that we must always consider. Number one are the patients. Number two are the telehealth providers, and the payer, somebody pays. So the value that each stakeholder treasures must be identified and well understood during stakeholders' engagement. For example, the patients who desire easy access to services through expansion, especially to the underserved and socially disadvantaged population. The patient will desire convenience. It will be a priority to them, and they will also desire improvement in their care pathways. On the side of the provider wants an enhanced workflow, increase in billable revenue, and improvement in the satisfaction of their patients. A clinician, for example, won't abandon a new technology if this technology allows him to care for his patients in a more enriching way. And the payer wants to see an expansion in access to care and an increase in prevention of morbidities and mortalities, and an improvement in the quality of care. Let me conclude by saying that in order to achieve universal health coverage, there is the need to prioritize innovative care models in the health system. Convenient care, and specifically the telehealth, is a growing industry in Nigeria, in the Nigerian health space. And so far, economic challenges in the country, COVID-19 pandemic, increased internet penetration, the brain drain syndrome in the health sector, insecurity, and increasing number of inaccessible settlements have contributed significantly to the rapid growth of telehealth in Nigeria. To achieve significant expansion in access, it is imperative for the government and key players in the sector to ensure the provision of policy frameworks that address issues bordering around telehealth reimbursements, registration and licensing, interoperability of data platforms, data protection, and confidentiality. These are some of my references. I want to say a big thank you to the CEO, SYNLAB, Dr. Kenneth Okolie, and all the officers responsible for this beautiful webinar. I want to thank you so much for giving the opportunity to speak. I want to say thank you to my co-speakers, Dr. Ola Brown and Dr. Bisola Adebayo. And very importantly, I want to say a big thank you to my wonderful listeners. Thank you.
Thank you very much, Dr. Adeniyi. Thank you so very much. I think there's been a lot of learning points from what you've just talked about. And I think by the time we're wrapping up, we'll try to unpack all of them. Well, thank you very, very much. I'm sure that there are several questions that are waiting for you by the time we start taking up questions. And it's a very interesting topic you talked about regarding policy as it relates to the necessary foundation for expanding access to convenient care. And I feel that this is very, very important. And while technology is a good enabler, if certain things are not put in place, we'll not be able to leverage off the opportunities it provides. Want to say thank you for that, for your thoughts on this, and for the robust comment around it. Next we'll be taking Dr. Ola Brown. Dr. Ola Brown is someone very dear to me. She's someone I've learned a lot from over the years, and she's quite a unique healthcare practitioner. She's someone who has been able to infuse finance and business very, very neatly into healthcare, and she's pivoted her career, or will I call it pivoting, or enhanced her career in the business aspect by layering finance and other things, investments and all of that on top of her MBBS degree. And I find that very, very commendable, and it's something I'm learning from. So Dr. Ola Brown is our next speaker, and a brief bio of her. Dr. Ola Brown is a general partner at HealthCap Africa, an investment firm focused on healthcare, fintech, and infrastructure. Under her leadership, HealthCap has backed nearly 20 startups valued at over $700 million, which has created thousands of jobs, promoting gender diversity. She co-founded Green Tree Investment Company, which achieved 25% IRR and was an early investor in Paystack, contributing to its success. With a background in medicine and in finance, I would say background in medicine, and then she also has developed capabilities in finance. She's currently completing a PhD in finance, researching on digital currencies, financial inclusion, and monetary policy. She's a published author of 5 books, including Economics, Banking, and Finance in Emerging Markets. And also, I think we all knew Dr. Ola Brown as the founder of Flying Doctors, which was one of our early entry into the business space, which is a tech-enabled urgent care platform that has responded to over 15,000 emergencies across 45 African countries. Ladies and gentlemen, please join me in welcoming Dr. Ola Brown as she takes us through technology as a catalyst for enhancing access to convenient care in Nigeria and in Africa. Thank you very much, Dr. Ola Brown.
Hi, and thank you for the invitation, Dr. Kenneth. It's great to be here. I hope everybody can hear me. And if you can hear me, just write in the chat.
Yes, we can. We can hear you.
So just to tell you, a bit about my presentation, I'm going to go just talk about myself and my work a bit more before going on to talk about sort of the waves of innovation that Africa has missed and why I think that we can win in the area of health tech. And then I'll talk about some health tech trends before I conclude. So about me. My name's Ola. I studied medicine because I was good at science and my parents said that people that are good at science should study medicine. But I did a few years of work in the NHS in the UK before I realized that, what I really wanted to do was start a business. So I moved to Nigeria, which was a bit of an odd move because I'd never lived here before and I was born and raised in the UK. But yeah, I kind of jackpad as soon as I got the opportunity, but probably jackpad in the direction that most people don't. And I came to live in Nigeria and I've lived here ever since. And I started a company. At that time, as a physician, it was very difficult for me to get investors. So I had to bootstrap the company with no external investment. I was eventually able to get a liquidity event from that company in 2015. And I started thinking about founders like me, that kind of want to start a business, people with medical backgrounds, people with backgrounds in microbiology, people with backgrounds in pharmacy. They want to start a business, but they're not business trained, but they are technically trained. And perhaps they don't have any relationships because like me, when you study medicine, most of your time you spend hanging out with other doctors. So you don't really even speak the language of business. I didn't really know anybody that studied business. Most of my friends were fellow physicians. So it was a really, really rough start in terms of starting a business without that background. And I felt like there might be a lot of people like me who were technically trained, but not business trained. So I wanted to start a firm that really focused on these types of entrepreneurs that were starting healthcare businesses across Africa and really investing in them, but also providing more than investment, providing mentorship, providing guidance, providing oversight, providing governance, and providing sort of introductions and other forms of support that could help those companies scale. Companies that do this are largely called private equity companies, but companies that do this at the early stage are called venture capital companies. And that's sort of the field that I went into in 2015, buying shares in companies and then adding value-added services to those companies and then selling that stake in the companies as soon as the companies matured. I also hold a master's in finance and economic policy and just finishing my PhD also at the University of London, also in finance. So I think about Africa and I think about, the 1 billion people in Africa currently living in poverty. And I look east and I see countries that were in exactly the same situation as us 30 or 40 years ago. Countries like China, countries like Vietnam, countries like Singapore, were all poor countries. Even countries like Saudi Arabia were poor countries. Countries like Brazil, when you look west, were also poor countries. And somehow, almost all of those countries, including India, have been able to find their way out of poverty. But Africa is unique in that it simply hasn't. And I think, when you look at history from like 100, 200 years ago, there've been four main waves that got people rich, that lifted people out of poverty. The first wave was the colonial era, right? So British people, Spanish people got on boats, traveled for many months across the sea, came to different countries and kind of just took over, conquered. and, you know, extracted resources from those countries. And that was the way people made money. It was a business of the day. And it's been the business of the day for quite a long time. And if you ever read the Bible, you like recall even during Jesus's time, right? The whole of Israel was under colonial, in quotes, rule by the Romans. So that has been a good business for a lot of countries for a long time. And Africa was never really involved in that. I can remember sort of reading about the history of my state, Ekiti. And, you know, Ekiti people tried to colonize somewhere. They tried to take over somewhere, actually. There was a big war between Ekiti and Oyo State. And in the end, we couldn't take over Oyo State, talk less of the UK or America or any far country. So it showed that probably we were not good at making money from colonization or slavery or whatever. So we missed that wave. And maybe it's a good thing that we missed that wave. The second big wave was the Industrial Revolution, when people started mass manufacturing. And when you think about businesses that were built in that era, you think about Carnegie, for instance, steel. You think about Rockefeller with refined sorts of PMS or petrol. You think about all the large manufacturing companies that could produce at scale and export. And, you know, Africa really also did not participate in that wave very much at all. When you think about mechanized agriculture, Africa didn't really innovate in that space. So we missed like two big opportunities. The third era where people kind of made money was in hardware, so phones, computers, cars, that kind of stuff. And again, like, just Africa never played in that space at all. We never made phones at scale. We never made cars at scale. We never made hardware at scale. And I'm not just talking about one African country. I'm saying the entire 54 countries never really played in that space. So now you think about three waves of opportunity, three things that made people rich that Africans never participated in. And, you know, when I hear people say, you know, Nigeria is bad because we have poor leaders, you know, I'm going back like 500 years, right? Have we had poor leaders in all 54 countries for the whole 500 years? And that's like our excuse for missing like all three areas of innovation. Maybe, you know, that could be a possibility. And then, you know, I hear those arguments and, you know, they're there and people articulate them. But I really think that what excites me and what gets me up in the morning and what makes me passionate and what I spend a lot of time thinking about is this software and AI wave that we're experiencing now. And I think this fourth wave presents a really unique opportunity for the continent to drive innovation, particularly in healthcare. And this really could be Africa's moment. I believe that Africa might be able to leapfrog traditional models, particularly in healthcare, by using artificial intelligence, by using software solutions, by building out marketplaces, by building on the blockchain. And this is, you know, the next big opportunity that I think that Africa might be able to take advantage of. And let's not forget that we've proven innovation in health technology before. In 1967, the first ever heart transplant in the world was actually performed in Africa, on this continent, in South Africa. And it was performed by a doctor called Chris Bernard, South African. So it really shows that we've been health tech leaders since the 1960s in some area. And I think, you know, if we've done it before, then it's possible that the next wave of affordable, accessible, and scalable medical innovations could once again be Africa-led. And it's that dream and that hope and that aspiration that really drives me to do what I do. And there's more evidence that, you know, Africans are really capable of building great software, and perhaps we have a comparative and competitive advantage when it comes to building software solutions. When you think about Kenya's Safaricom, when you think about Africa's leadership in the area of social finance and digital currencies, when you think about the fact that 70% of all mobile money transactions happen on the continent. When you think about, particularly in Nigeria, African or Nigerian banks have dominated Africa. When you think about banks like Access Bank, when you think about Guarantee Trust Bank, and you think about the way that they've completely dominated West Africa, Central Africa, Kenya, South Africa, and there's a Nigerian bank that I hear that's even buying a banking in Egypt. We do have this competitive and comparative advantage in software, in banking, in financial services. And I believe that we can really roll this all up if we begin to recognize it and double down on it to create a comparative advantage in healthcare innovation as well. The biggest transaction in early stage technology ever to happen in Africa was actually a healthcare company. There was a Tunisian company called InstaDeep that was sold for almost $1 billion to one of the biggest biotech companies in the world, Moderna, in 2023. And it was the largest exit of an African startup ever. So just to think that African software and African know-how and African technology is now at the heart of major drugs that are being produced by one of the biggest drug manufacturing companies in the world. It's a clear signal that Africa is ready to lead the future of healthcare innovation. And one thing I think about as I travel from Cairo to Cape Town to Nairobi to Togo to Morocco is Africa actually really does have an enabling environment for healthcare. In the EU and the US, there are really strict regulations that slow down healthcare advancements and delay new medical technologies for years. But Africa actually does have a more flexible regulatory landscape, and that allows startups to kind of test or refine and scale solutions faster. And this agility really helps these startups to get deployed and improved in real world situations, really accelerating that innovation. So by moving faster than traditional markets, Africa isn't just solving local healthcare problems. I believe that we hold the potential to really shape the future of global health tech. Now, one of the issues that we face in Africa is ability to pay. Africa's average GDP per capita is just around $2,000. Now, I know that there's a lot of medical people in the room, so I'm going to explain what GDP per capita is. GDP per capita is if you take all the money in one country and divide it by the number of people, you get GDP per capita. So I think what a lot of people don't realize is even if we took all the money that Nigeria makes without any stealing, without any corruption, and divided it by the number of people, most people would still only get 100,000 naira per year. As a country, we just don't make that much money. And I think it's really difficult for people to get because they hear about this oil and they hear about all the money being stolen and they think, oh, we're a super rich country and all they need to do is share it properly. But the truth is, if you took all the money and divided it by the number of people in Nigeria, you'd get just above $100,000 per month per person, or about just over $1,000 per person in dollars. If you did that same division in a country like South Africa, you'd get $6,000 per person, which is 6 times more than Nigeria. If you did that in a country like the UK, for instance, took all the money and divided it by the number of people, you get $40,000. Remember I said it's about $1,000 in Nigeria, you get about $40,000 per person. If you did that in America, you get $60,000 per person. And if you did that in a place like Qatar, where there's Arab money, you get about $80,000 per person. So the low spending power, the low amount of money that Nigeria makes, the low GDP per capita, the fact that, countries make money by making things, and if you don't make things, then you're not going to be a rich country. And that's it's something, I believe that there's something to do with the leadership, but it's more to do with like creativity, right? Even if you have the best leaders, it's very, very difficult to make people or force people to like start really big companies. So the companies stay kind of small. But I do think that, like I said, maybe we weren't good at starting industrial companies. Maybe we weren't good at the manufacturing revolution. We definitely were not good at colonization, and that's a great thing. But I think that this software, we're actually good at it. When you think about Paystack, when you think about Flutterwave, when you think about MoneyPoint, when you think about M-Pesa, when you think about anything to do with like the most robust and interesting software companies in the world, you have to think about Africa. You can't leave Africa out of the equation, particularly in the fintech world. And one of the biggest sorts of incubators of startups in the world put 2 African companies on its most profitable list. So not only are we building, but we're building profitably and we're building in a scalable manner. And I think for health tech, even though this low GDP per capita, low spending power, inability to pay is a disadvantage in a way, it may also be an advantage because it forces health tech innovators on the continent to build really cost-effective, scalable solutions, which can be an advantage because everyone in the world wants cheaper healthcare. And if Africa can produce better with less, just like China did with manufacturing, if we can do that with software, then we're really onto an opportunity. China got rich by being able to produce great stuff cheaply, but they produced manufactured goods. They produced phones, they produced cars, they produced air conditioning, they produced garments. What if Africa could do that with software? Wouldn't that be an exciting thought? So I'm going to finish with some of the health tech trends that we're seeing and some of the companies that we're seeing in Africa inside and outside our portfolio. And the first big trend, as everybody on this call probably knows, is artificial intelligence. And one standout company in our portfolio is InstantRad, which uses artificial intelligence to recognize X-rays and scans with greater accuracy, not replacing radiologists, but assisting them. And this is technology that we see is super exciting. The second big trend that we see people building is marketplaces and aggregators. So single platforms that link highly fragmented spaces such as individual clinics, pharmacies, supply chains together, ensuring cheaper and faster care. Another big trend that we see is genetics and clinical trials. And we think that Africa hasn't played in this space so far, but we do have the expertise and we do now have begun to build the infrastructure to be able to really begin to play strongly in this space. And it's a pipeline for foreign revenue, for strengthening our economies, as well as putting Africa at the forefront of medical research. Imagine, a Nigeria where our smartest biomedical scientists and biology graduates and physics graduates and physiotherapy graduates and other deep science graduates can actually work as scientists and not in Access Bank or Zenith Bank. That would be, pretty amazing. And the fourth big trend that we see is public-private partnerships and scaling healthcare through smart collaboration. We're not looking for companies that rely solely on government, but we think that PPPs do come in to offer a powerful way for startups to scale while driving impact. So those are the four trends that we see from an Africa to Africa perspective. But the fifth trend is the trend that we see from an Africa to the world perspective. And the reason why I put a whole slide on InstaDeep is actually InstaDeep built technology that was bought by a massive German company, which is now being used to supply healthcare to everybody in the world, almost every single country. And we believe that that's the beginning of a trend where Africa will no longer be just a consumer of global innovations, but actually creating solutions that the world needs as well, and exporting technology, just like India does. So in conclusion, Africa may have missed the Industrial Revolution, the technology revolution, but we believe that health tech driven by software and AI and innovation really presents to us an opportunity that we can't afford to miss. And we've already seen glimpses of our potential in the technology space, from the world's first heart transplant to the rise of mobile money to major, big, massive billion-dollar, almost billion-dollar exits like InstaDeep. What gives us an edge is having a dynamic ecosystem. Nigeria is the largest startup ecosystem in the whole of Africa. A disciplined approach and that ability that we've already shown to be able to leapfrog over outdated systems. And the trends shaping these investments, AI, marketplaces, genetics, PPP, and global scalability are really positioning or beginning to position Africa as a leader in health tech innovation. And we believe that this is just the beginning. Next month, we'll be launching our African Health Tech Unicorns report. So stay tuned for more stories about what the smartest and brightest and most exciting innovations in African health tech across the continent are doing. Thank you so much for your attention, and I hope that this was useful and maybe even a little bit inspiring.
Thank you very much, Dr. Ola. I think for me, it's been insightful. You know, sometimes when we talk about the challenges we have in Africa, we really do not get a grasp of it, especially when we compare what is possible, what is happening in the US and the UK and Europe, and we say, oh, in Nigeria, we can't do this. And when you begin to look at data, looking at, like you pointed out, the GDP per capita, imagine the GDP per capita in Nigeria, equivalent of $1,000. In South Africa, it's about 4 times that. In the UK, it's 20 times that. And the US is 40 times that. It just tells you, and that's why some of the conversations we've been having is that there is not enough money. And this brings into play what role the private sector can play, because the government can't do all of this. How can we attract more investors? How can we do a lot of things? And how can we build better things that would last? Okay, and these are some of the questions we're going to come back to after the last speaker. But thank you very much for those quite thoughtful comments around the topic. Thank you very much. So over now, I'll be bringing on our last speaker before we begin to take questions. I can see a lot of people already asking thought-provoking questions. Quite some people are even asking the questions with some emotions. So our last speaker for today is Dr. Bisola Adebayo. Dr. Bisola Adebayo is a public health physician and epidemiologist with expertise in epidemiology, emergency preparedness, and health policy. She's a senior lecturer at the Lagos State University College of Medicine, and an honorary consultant at Lagos State University Teaching Hospital. As the pillar lead for epidemiology and surveillance at the Lagos State Public Health Emergency Operations Center, she has played a key role in Lagos State response to major disease outbreaks such as COVID-19, Ebola, and cholera. Her work in developing electronic surveillance tools has significantly enhanced outbreak response efforts. Dr. Adebayo is a fellow of the National Postgraduate Medical College of Nigeria and a graduate of the Nigerian Field Epidemiology and Laboratory Training Program, Advanced. She's also a researcher, mentor, and published author, committed to strengthening public health systems through evidence-based interventions. Please join me in welcoming Dr. B.C. Adebayo as he takes us through the topic, addressing social and community barriers to healthcare access. Thank you very much. Dr. B.C., the floor is yours.
Good afternoon, Dr. Okolie. I want to thank you and SYNLAB for having me online this afternoon. And it's good to see you again. We interacted quite frequently during Ebola. I also want to appreciate the speakers that went before me, Dr. Adeniyi and Dr. La Brown, who I also had the opportunity to meet briefly during the initial period when we had COVID. I think you'll agree with me that the previous sessions have been very thought-provoking and stimulating. So I'm going to focus now on addressing social and community barriers to healthcare access. So I'm going to take you from the high that we had with Dr. Ola to the basics all over again. And, I thought of it when people say social, cultural, everybody knows, okay, there's poverty, there are gender issues, educational issues in the country. But I think this afternoon, I want us to just look at the overview of the Nigerian healthcare access landscape. I remind ourselves what healthcare access is, and it's not just a point, it's a process. And then to understand the social and cultural barriers, and we're going to use a framework. So we see how these things we think we know, commonly how they fit into the different dimensions of healthcare access. And then we'll just briefly look at the strategies to overcome an environment, and we'll look at what people have done. So just to remind ourselves, we know Nigerian health system is pluralistic. We have a lot of public hospitals, majorly primary healthcare centers. We have a myriad of private hospitals, and studies have shown that private hospitals account for about 70% of healthcare provision in Nigeria. We also have the traditional and modern. And when we say traditional, it's not just the TBA or the traditional medicine people. Many people online also use complementary and alternative medicines as well, even people that are well educated. And it's three-tiered, that we have our tertiary facilities, we have the general hospitals, which are secondary, and then we have our primary healthcare centers. And these are administered through the federal, state, and local governments in terms of regulation. And now when we look at our health infrastructure, the picture we have generally is that it's not yet where it should be. There's a lot that has been done. We talked about how we only had 30% functional PHCs. I think that has increased to over half in the last scorecard, the joint annual review that was presented by the Federal Ministry of Health. But we still have a lot of facilities lacking essential equipment, drugs, as well as trained personnel. In terms of financing, our current budget only allots 5.18% to health, and this falls far below the 15% that we're still aspiring to. On the good side, about 5 states are at 15% already. Payment for services is about 76% out of pocket. And then we're still at that 5, less than 5% are still insured in the national health and enrolled in the National Health Insurance Scheme. However, Nigeria has about a $1 billion medical tourism industry. That's outwards, not inwards. So it's really another space that we should be looking into. And our healthcare industry is actually valued at about $18 billion. In terms of health products, and I must mention that because that's another angle that I think the country is trying to go to in terms of our value chain, in terms of production. One of the key gaps is that 99% of the products we use are imported, even as small as consumables. I was listening online, and someone was complaining that we had a very, a robust production company in Cross River that used to produce syringes and all that, and they've closed. And now many times we're importing even substandard, syringes and needles. Now, about the health products in Nigeria, they must all be registered by NAFDAC and Standard Organization of Nigeria prior to importation. Now, looking at our key indicators, we're above 200 million. Current health expenditure is 4.08% of our GDP, which Dr. Ola Brown just explained what it is. We still have a young population, about 21% are between 0 and 14 years. Our life expectancy is 63.4 years. It's slightly higher in women and lower in men. And global life expectancy is 72.9 years. Healthy life expectancy, which is how many years a person is expected to live in full health, is about 54.9 years. For the world, is 61.9. We still have an HIV incidence of about 34 per 100,000. But I must say we are on the downward trend. TB incidence too is stable at 219 per 100,000. And then malaria, of course, is still a problem, but we're doing a lot. And then we're also monitoring things like hepatitis B, which can cause long-term ill health effects, and our prevalence in under 5 children is 2.94%. And we're monitoring them because we expect every child that is under 5 to be fully vaccinated against hepatitis B. Now, looking at the causes of death, if you look at this slide, you'll still see that Nigeria is still dealing with communicable diseases, even in 2025. So we have for male and we have overall. So top causes of death are lower respiratory tract infections, still malaria, diarrheal diseases, TB, ischemic heart diseases, and all that. So if you look at the broad cause, we have communicable diseases that are responsible for about 63.7%, non-communicable diseases 27.7%, injuries 7.8%, and COVID-19 related outcomes 0.8%. This data is from WHO, and then we can look at it by gender as well. And now these are things we don't commonly talk about, and I just wanted to bring it to our consciousness. Probability of dying from an NCD in Nigeria is 17% in those 30 to 17 years. Road traffic mortality, 17.2 in 100,000 of our population. Homicide, 9.16. Suicide mortality rate, 3.49 per 100,000. Unintentional poisoning, 3.27. Mortality due to air pollution, 175 per 100,000. And then due to unsafe water, sanitation, and hygiene, 71.7 per 100,000. So I just wanted to bring this to our consciousness. So we're not just thinking about those common diseases that we know, and that so that people can also look at, what angle they want to come in to support the health sector. Now, we always talk about key childhood mortality indicators because it tells us how healthy we are as a nation. So we're on the downward trend for most. Infant mortality has been dropping. We can still do a lot better. Under 5 has been dropping. Neonatal is sort of just stagnant. And then trends in vaccination. The red line shows children that are not vaccinated at all, while green is fully vaccinated with the basic antigens. Those are the vaccines in our national program on immunization. So we're still not doing so well. We're still at 39%, but we're getting better. So we still have to keep pushing them. So that's just a brief, a brief look at our health profile as a nation. So now we come back to access. So Dr. Adeniran has already mentioned what it is. So access is having timely use of personal health services to achieve best possible outcomes. And it's also the ability to find qualified healthcare providers, receive timely services so that people are able to live their healthiest life, their best lives. When you have access, it saves lives, it saves money, and it also improves population health across board. And we talk about access a lot because marginalized and vulnerable populations often have barriers in receiving the kind of healthcare that they should, often due to these factors I will mention. And in summary, most of these are socioeconomic disparities, limited availability or access to providers. And then you also have systemic biases and discriminations, even in our system, and of course, inadequate resources and infrastructure. Now, access to preventive and curative interventions. And I brought this because I remember when insurance first started, the focus was just primarily on curative services. They didn't even want to add a lot of preventive services. But now things have changed. For example, the Lagos State Health Insurance Scheme, family planning is one of the services that are offered. Even some health insurance providers offer gym membership. So prevention is as important as cure. So access is one of the two components of universal coverage, and the other is protection against financial hardship while you are accessing these services. So we can see that access is a complex concept. Some people call it coverage or utilization, but it's more than that. First, you even have to recognize that you have a need for these services to even be able to think of accessing these services. And that brings me to the next thing. So I'm just trying to look for a framework that would sort of explain what we're talking about today. And this is just the framework for healthcare access after the best. And it looks at both the supply and the demand side. So we have on the supply side, we have approachability of healthcare, acceptability, availability, affordability, and appropriateness. Sorry if it's not so clear. We're still going to look at it in detail. So each of these supply side factors has, what will I call it? It's a tag team. On the demand side, you now have ability to perceive, ability to seek, you have ability to pay, you have ability to engage. So they go hand in hand, because many times we're looking at access, we tend to focus on supply side, the issues with the health system. But if we get that right and we don't get demand side right, then we're going to have those services and we're not going to have people that are even looking for them. So if we think back, if we're looking at a healthcare journey, we're looking for services, you even have to first perceive that there's a need for those services right through receiving the successful services. And when we say successful, it has to be done in a way that is satisfactory to the person that is also receiving those services. So the framework speaks to healthcare access being achieved through interaction of supply side factors and demand side factors. So this is it. We're moving all those fancy things. So we can just see them: approachability, acceptability, availability, affordability, and appropriateness. And then supply, we have ability to perceive, ability to seek, ability to reach, ability to pay, and ability to engage. I'll just briefly look at the definition of this, because I know this is why we're here. We're talking about access so that we even understand and we don't have a myopic view of what we think access is. So approachability is the ease at which individuals can find, access, and interact with healthcare providers. So it includes things like communication, location, and even the staff. And I say that because, when in meeting or family planning, and somebody that is actually a health worker, well, not directly, but she was part of the stakeholders there. She stopped family planning services because she went there and she felt, she wasn't attended to in a way that she was satisfied with. And she went back to non-modern, modern contraceptive family planning methods. So those are the kind of things that, can affect access to healthcare services. Now, acceptability speaks to factors that affect an individual's ability to accept or seek healthcare. And the judged appropriateness, that means I'm seeking healthcare that I feel I should, that is acceptable to me. And you find out that some of these factors overlap. So it has to do with the infrastructure. Many people don't go to primary healthcare centers because they feel, how will I go to a PHC? But let me tell you, I remember the first day I went to Mosonkwola, a health center in Alimosho. All of us were like, is it a private hospital or is it a health center? You have 3 floors, one whole floor for the maternity, for children. You have wards, you have a dental office, ophthalmology. We were sure, so things do happen. But you see, people already have that perception that PHC is this way. Meanwhile, in many developed countries, that's the first place that an average person will go. And then the hours of operation also have to be acceptable to people. Now, availability refers to healthcare services and those within it being reachable, both physically and in a timely manner, and existence and sufficient quantity of healthcare services to meet the need of the population. Now, one thing, if we don't have sufficient, that's when you have queues. That's when people are calling you that, oh, my partner has been at the hospital since 6 a.m. It's 2 p.m. They've not been seen. That means there's a gap somewhere.
Good afternoon, everyone. I'd like to say welcome to the continuation of the podcast. Oh, sorry, of the webinar from the last session. And we would like to just take a moment to sincerely apologize for the break or the incidents that happened the last time. As an organization, we've taken steps to mitigate such incidences and ensure there are no repeat occurrences. We've also decided to ensure that we have a proper conclusion to the webinar, to ensure that every participant has some closure. We got questions from participants and we've brought our guests back to be able to take up those questions. And within the next few minutes, we'll try to wrap up the session with those questions. All right. And the questions will be thrown to the guests, and either guest is happy. It's okay to respond to a question or give more thoughts or insights to a question, even if it is not directed at you. So I'll be starting with Dr. Adeniran. And you were speaking on the topic policy as a foundation for expanding convenient care. And one of the questions that was projected was, given Nigeria's current health care infrastructure and funding limitations, what key policy shifts are most critical to ensuring that convenient care becomes a standard rather than a privilege? I'll go over the question again. Given Nigeria's current healthcare infrastructure and funding limitations, what key policy shifts are most critical to ensuring that convenient care becomes a standard rather than a privilege?
All right, thank you. Good afternoon, Dr. Kenneth. Good afternoon, colleagues, co-speakers, Dr. Adebayo. Welcome to this session.
Yeah.
Yes, aside the point I made that currently in Nigeria, there is no specific policy that is directed or targeted at regulating the telehealth industry or expanding access to convenient care. But I mentioned some policies that have direct or indirect influence, regulatory influence on expansion of convenient care and telehealth. However, I want to say with all level of confidence that with the support that Nigeria has received from the World Organization and other organizations, Nigeria does not really have problem with policies. We have very good policies. The challenge is, one, implementation of those policies. The political will at national, at subnational level to get those policies implemented, because health policy, that's what we call the politics of health policy. So there are political implications of implementing some very good health policies. Some very good health policies, if or when properly implemented without proper orientation of the people, it might cause some political leaders probably their political positions or their next political bid or something like that. So there is politics around implementation of some policies. So sometimes we look at some beautiful policies, but for some of us that are into health policy and health policy analysis, we know that some beautiful health policies have negative political implications on some political leaders. So what I'm trying to say is that we have good laid down policies. What we need now is, number one, the political will of leaders to implement some of these policies to the letter, and also to do proper stakeholder engagement through agencies like the National Orientation Agency, our media houses, to let people know why these policies must be implemented. And number two is that the infrastructure that we have in place to implement policy. When you don't have proper infrastructure in place, then you are only illegally empowering the law enforcement agents by the time you start implementing some policies. For instance, let me just give a policy outside the health sector. If you just make a blanket policy statement that, okay, because of road traffic accidents and the injuries you're having from motorbikes, commercial motorcycles in the metropolis, we are going to ban the use of commercial motorcyclists. Now, you have not created good roads for taxis or private taxis like the ones we have, like Uber, them to move. So immediately you stop those commercial motorcyclists, what you have caused is pain. You have inflicted pain on the people. And you have also empowered law enforcement agents to start arresting people illegally. Just arrest bike riders, extort them and things. So what I'm saying is that apart from the fact that we need the political will of leaders to implement already the beautiful policies we have, we also need to look at the infrastructure available before we start enforcing some laws. Some policies are made under the assumption that some infrastructures are in place they are made under the assumption that we have electricity. Some policies are made with the assumption that there is good internet penetration. Some policies are made under the assumption that we have enough human resources at the health facilities. So if these assumptions are not met and we begin to enforce some beautiful policies, then number one, the political future of that implementer or that the person implementing the policy is at stake. Then number two, there will be chaos. So that's why sometimes as health workers, we need to also have the mind of the political implications of some of these policies. So in conclusion, what I'm saying is that we don't really need a major policy shift, apart from the fact that if all these policies can come together and now get a policy that will be specifically for the expansion of convenient care or the telehealth industry, that is the only policy we don't have now. Outside that, we have other beautiful policies. What we need are, one, the political will, and two, the infrastructure must be in place to implement those policies. Thank you.
Thank you very much, Dr. Adeniran. I was as I listened to you, I was just cracking my head. I was like, okay, so what then do we do? But interestingly, I think there are some questions that we already maybe had already preempted these thoughts and maybe preempted your answer. So the second question, which also comes to you, says many well-intended healthcare policies fail in implementation. What practical, and at this point, it's what is practical? Let's forget about the theories and everything. But what practical strategies can policymakers adopt to bridge the gap between policy formulation and real-world execution in healthcare access? And maybe I should give some practical insight. Well, let me read the question again, and I'll just give some context. There are many well-intended healthcare policies fail in implementation. What practical strategies can policymakers adopt to bridge the gap between policy formulation and real-world execution in healthcare access? And let me give an example. We have primary healthcare centers across the nation and in Lagos State. And while the state government is doing its best, investing as much as it can, as much as it should, but we still see that there is a gap. You go to some healthcare centers, there is no power, it's not well taken care of. You can't put all the blame on the government. Some of the times you're asking who is the person managing, who is overseeing this healthcare center? Why is there no proper running water? Why is there no diesel in the generator? Why? There's so many whys. Okay. So from your own perspective, we're not talking about grand ideas right now, but what are the simple things that can be done at these basic centers, okay, that would help improve access? Because again, in driving access, there should be infrastructure. Now there's infrastructure, but maybe it's not well maintained, or there's not enough this, there's not enough that. What can be done both by the private sector, by the public office workers in that place, by the government, to ensure that, or to improve the quality of services delivered that would, of course, enhance access to the immediate community at the end of the day? What are your thoughts on this?
Thank you, Dr. Kenneth. If we look at it practically, what I would call the silver bullet that probably will solve more than 50% of the challenges we have in terms of access to convenient care is the health insurance. And I'll say that again, is health insurance. Okay, I mentioned earlier that we have policies. I'm sure you are aware that the National Health Insurance Scheme, now called National Health Insurance Authority, has made insurance compulsory for all Nigerians.
Yes.
Now, this was gazetted in 2014. I have the document here with me. I've read through it. Now, since 2014, this is 2025, 11 years down the line. What is the proportion of Nigerians with health insurance? From Dr. Adebayo's presentation, I think still around 5%. Well, 5%. In Imo State, for example, we still have 92% of residents
Mm.
that are incurring high out-of-pocket expenditure,
Mm.
and in fact, catastrophic health spending. So the
Mm.
first point is that if we are able to drive health insurance such that everyone knows that
Mm.
accessing healthcare service will not cost me extra, or
Mm.
will not tilt me into poverty, or
Mm.
it will not worsen my current poverty state,
Mm.
then that is the first track towards expanding care. And it's going to
Mm.
be a win-win for both the patient, the payer, and the regulatory bodies.
Mm.
So the first thing that I can see as a silver bullet is that if we don't do, we are not ready, because nobody collects salary and budget for sickness.
Mm.
Nobody collects salary at the end of the month and say, okay, this one is for food, this one is for sickness. People don't do it. So the only way the government would budget compulsorily for sickness for people is to deduct a particular portion of their income and get it prepared for access to care. So the only silver bullet I know for now, that if the government is able to drive, that will expand access to convenient care, including telehealth, is the health insurance. Now, secondly, is what I personally feel that we can implement. That's the phased implementation. No matter how beautiful the policy is, we need to consider, as I said, the infrastructure and other things in place. So if there's any beautiful policy now, we can consider phased implementation. Phased in terms of one, geographical area. When there's a policy, we could start from, okay, where are the areas that have lights, electricity supply, that have good road access? Okay, in so area, we're implementing this policy 100%. But in this area, we're implementing so component of this policy because of lack of this, lack of that. So I consider phased implementation, phased in terms of the geographical areas, and also in terms of the beneficiaries. Some policies might start from the under 5 children. Some policies might, after under 5 children, we can now move to, okay, let's include pregnant women, just like the way we implemented COVID-19 vaccination. When we succeed with pregnant women, we can now include, okay, all women, before we now get to the entire population, based on the available infrastructure and the responses we are getting from each phase. If after implementing among under 5 children, the response is good, the coverage is okay, there are minimal challenges, then we can move to the next level of implementation. So 2 things. Number 1, compulsory health insurance. Let every government drive it to the letter. With that, we'll have solved more than 50% of the challenges we have with expansion or expanding access to care. And number 2, we can also implement phased implementation of policies. Thank you, sir.
Thank you very much, Dr. Adeniran. I really appreciate your thoughts on this. I see Dr. Bisola's hand is up. I think she wants to contribute. Dr. Bisola, the floor is yours.
Thank you, Dr. Okolie. And I think Dr. Adeniran has said everything. The part I want to bring in is from the other end. I think one other problem we have is that we're not assessing our progress well enough. We're not doing enough in terms of monitoring and evaluation. For example, when we do all these things, we have all these initiatives, do we come back and assess how well we have done, what is left? So I think that's sometimes a problem. How many times, we're saying we're building health centers, we're equipping them, but are we doing them based on a baseline that we have gotten? So we should first have a baseline and measure our progress regularly so that we can know this is what we have left, so that even if we have private sector donors that want to come, they already know where they are plugging into. And that brings me also to the issues of scorecards. Now, in terms of family health sector, I think they've done well in this. If we know about like the maternal and perinatal death surveillance and response system, you'll find out that they've maintained scorecards religiously. And they can give you scorecards for every quarter, years, so they know what they are doing. What do we have left to do? How well have we done? Looking at both demand side and supply side. And I think this is one thing that we need to introduce. So we're not just talking arbitrarily. We're not just creating initiatives, but it's based on evidence. It's based on data. It's based on monitoring and evaluation and assessment of programs. that we are implementing. So that's just the other side I want to bring in to add to what Dr. Adeniran has said. Thank you very much.
Thank you very much. Thank you very much, man. Like Dr. Adeniran also has something to add. Go ahead, Dr. Adeniran.
Yes, thank you. Just to buttress what Dr. Adebayo said. So we also need to strengthen our data management system because in order to succeed in that monitoring evaluation, we need good data. So from my field experience, in fact, I'm conducting a particular project presently that I might not be able to say it publicly, that it failed even before it started because we planned based on wrong data. So wrong data is worse than no data. So for us to get it right, like Dr. Adebayo said, we need data. We need to strengthen our data system. We must have correct and accurate data so that we can plan appropriately. This is a major problem we have in Nigeria. Our data management is poor. Our data collection system is poor. Our interoperability of data platforms is poor. I cannot open SUMAS and from SUMAS access data from ETB Manager. I cannot open SUMAS and from SUMAS access data from DHIS2. You understand? There are some, you get data on SUMAS. The age disaggregation will be different from the age disaggregation on DHIS2. The age disaggregation on DHIS2 will be different from LMIS. So by the time you put those data together, you will not be able to make serious meaning from the data. So just to buttress what Dr. Adebayo said, we also need to handle our data management system properly. Thank you.
Thank you very much. Thank you very much. I really appreciate your thoughts. Okay, so I know Dr. Adebayo was not able to finish her presentation the last time, but I think she had gone quite far. And there are some questions that had been raised. And if you're okay, I would like to proceed with the question. Is that okay, Dr. Adebayo?
Please go ahead, sir.
All right, okay. So, in speaking to the topic addressing social and community barriers in healthcare access, one of the respondents then asked, healthcare inequity, okay, healthcare inequity or inequality, if I was to use that, often stems from deep-rooted social determinants such as poverty, education, and cultural beliefs. What are some proven, scalable, community-driven solutions that can break these barriers? Let me take that again. Healthcare inequity often stems from deep-rooted social determinants such as poverty, education, and cultural barriers. What are some proven, scalable, community-driven solutions that can break these barriers?
Thank you very much. So first, before I answer that question, there are some key things because inequity causes difficulties in access across board, both from the side of the person accessing care and from the side of supply in care. So many times, one of the key problems that we even have beyond what is obvious. So, when we talk about access, many people immediately think of issues around infrastructure, as well as siting, like siting of health facilities, distribution of health personnel. But what we've often seen is that many people are not even aware of the needs, of their own needs. They're not even aware of what kind of healthcare they're supposed to have. So we find out that even expectations are low. So what this translates to first is that health literacy is even poor. And when health literacy is poor, people come to the health facility, they don't even know what to expect. They don't know what standards they're supposed to expect from the healthcare provider and all. So one of the key things first that I think people have done from the demand side that is scalable is in terms of improving health literacy. And I tell you that health literacy is even different from education. If you notice, an average Nigerian mom, even educated, you ask, okay, your child was sick, what they give you? I don't even know. And this person is a lawyer. So we're taught not to question authorities, not to question doctors. and all that. So those are the first things, so that people even know what they should be demanding for. So first, I think we have health literacy initiatives. It's important so that people are aware of their rights. People are aware of what they should demand from healthcare providers. People are even aware of even many of these issues, even issues about rejecting vaccination, which is free, which is, you find that vaccination is free, it's open. Yeah, during the last outreach we had that we're trying to reach millions of Lagosians, we still found a lot of people rejecting common vaccines like yellow fever because they are unaware, because of misconceptions, because of miscommunications. So the first thing I think is first risk communication strategies, which I think they are working on, and that has changed in that now we're not just doing health education for the sake of it, but we're trying to base health education on data. The same thing Dr. Adeniran said, first of all, assess your community, assess your target population, where are the gaps? And then you develop communication based on this. So this is the first part. Then I think another thing, when we now come to the usual issues of equity, Nigeria has a lot of hard to reach areas, and many times our mainstream health facility services, they're usually inflexible. They are fixed. You have a fixed time to come to clinic. You must come on Tuesday for immunization. So another thing that I think is scalable that Lagos State in particular is adopting now is flexibility. So now you have morning clinics, you have afternoon clinics, even in like our own center in the tertiary facility, so that people don't have to stay and wait all day. Meanwhile, they are losing an income because many people are self-employed. So it's in terms of making our health services more flexible. And then in terms of inclusivity, I know we see mobile clinics a lot, but they are doing a lot. So many times you have elderly, you have people that are disabled, you have people that are not able to access mainstream healthcare services because of these issues. And now you have a lot of partnership between private and public sector so that you can take healthcare to people. And then instead of creating a parallel system, you are trying to integrate it with mainstream care. So you're establishing linkages between this mobile clinic. So it's not just a mobile clinic that is just there for the sake of being there, but they also tap into mainstream. If they need to refer patients, there's a referral mechanism and all that. And so we've seen examples of that. We have in the Southeast, like Packers Mobile Clinic. We have what MTN was doing, even within the state immunization sector. Now it is compulsory that every center offering immunization must also conduct outreaches to hard to reach communities. So I'll just stop here if Dr. Adeniran has anything to add, because this is the whole crux of the whole presentation. So these are just some of the scalable things that we've been able to do. So first, you have to create demand, you have to teach, you have to educate people so that they even know what they're asking for. Because you find out that even people that are disenfranchised, they still ask for less than people that are privileged because they don't know any better. They don't even know what they're supposed to be asking for. So first, we have to build health literacy. Then in terms of even insurance, you have to build financial literacy amongst our people too, so that they can have innovative ways of accessing healthcare. And then just to talk about insurance briefly, when we say community-based insurance, in states that are cosmopolitan like Lagos, the communities may not work the typical way. In fact, many people don't know their neighbors per se, but you have communities established around people's occupations. And I think that's another thing people are looking at. So you have communities of hairdressers. They always have meetings. It's compulsory. They live by regulations and rules. Even vulcanizers, they have rules that guide them. They set prices and all that. And those are opportunities people are looking at to introduce community-based insurance based on the peculiarities of communities that we have in places in Nigeria like Lagos, Rivers, and all those cosmopolitan towns. So I'll just stop here for now. Thank you.
Thank you very much, Dr. Adebayo, because I think this question is quite an important one, and it actually leads to the next one. And why I feel it's important is because oftentimes we don't really many people do not really understand how that sometimes the issue is not even the accessibility or the availability of care, but these barriers. Okay, imagine trying to deal with a population that is where there's a high belief that there's a high spiritual belief, okay, or dealing with the population where there's some form of cultural belief as to why certain things happen to certain people, it will be difficult for them to accept even what you're bringing to them. Okay, and that speaks to the demand and supply you talked about, because there's no demand, or let me say there's an intrinsic demand, but the cultural barriers or the educational barriers are serving as a shield to you being able to assess those demands, or even the people who require the services to recognize that they require or they need those things. Okay, and this is where consistent engagement, education comes into play. I remember speaking with Dr. Richard one time, and he said anybody who wants to do healthcare in Nigeria or anywhere in sub-Saharan Africa without a huge budget for medical literacy, medical education, you're not ready to start. Okay, because you don't fool yourself by the glitz and glam of the billboards you have in Lagos. Even in Lagos, you can have billboards and social media marketing on in VI and Ikoyi, but by the time you start getting to the Akuonjos and the deeper parts of the city where you don't have as much, with all due respect to people who live in those areas, but they are not as sophisticated as perhaps the people you have on the island. You'll begin to see that you need to be able to engage them on a different level, and your inability to do that will limit your ability to actually deliver the value that you intend to deliver to them. And this brings me to the second question, which is actually a follow-up to this first one, which says that a mistrust in healthcare system is a growing issue. And I think this is due to several mishaps in the past. We saw how I've forgotten the name of the company now, the vaccination issue in the north that led to different forms of mishaps among the young, which then caused, sorry, Pfizer, right?
Pfizer, yes.
Yeah, which of course led to a mistrust in further. In fact, it was a huge limitation. I don't want to imagine what the Gates Foundation and others did in convincing people to take the polio vaccine, because after that Pfizer incident, it was a big issue. Okay, to get people to agree to take any other thing free from people, even if it was going to help them. So mistrust in healthcare system is a growing issue, especially in underserved communities. And the reason I believe, one of the reasons I feel, is because oftentimes these on people in underserved communities sometimes, sorry to say, are being used as guinea pigs. Okay. In a bid, oh, we want to help them, but sometimes they're experimental drugs, experimental things being used on them. And in fact, how they are protected is a different conversation. But the question is, how can healthcare professionals and policymakers rebuild trust and ensure communities actively engage with healthcare services? Okay, and I think a clear case study would be in northern Nigeria, especially in the remote part of northern Nigeria, and some parts of the middle, or even the southwestern Nigeria, where they have first-hand experienced what's it called? Mistrust, or they've experienced things being not done in the way they expected. How do you then rebuild trust, even when you want to do things that are in their best interest? From a policymaker perspective, or from a healthcare professional perspective, what would be your recommendation, and how would you say this should be addressed? Because these are some real issues. Dr. Adebayo.
All right. For me, first of all, like we said, the issue of mistrust is increasing. Like during COVID, it happened again. And, because there were all sorts of controversies, and because of the reach of social media, it's so fast and it's so wide, that also increased, and it's spilling over even till today. So I think, first of all, you have to start from the basics. For me, it's the easiest way. So, to be honest, before we come to the issues of us, using our own advocacy skills, the honest truth of the matter is that the kind of services we provide in our primary health centers has a long way in affecting our communities. That's the honest truth. Because you see, when people have personal engagements, then it's difficult for them just to be easily overweight by what they read on social media, because they know what they see. To me, that's the honest truth. And I'll give you a typical example of a place where I've seen they're doing well. There's a health center not far from Alausa that is called Alausa PHC. And in Lasuth, we used to go there as residents, to spend time. And I could actually see what we meant by primary health care. The nurses know them. They know when Mama Rizika has not brought her daughter for immunization, and they will send maybe the child to go and bring them out of the house. So they are so integrated into their community that if there is any issue, their communities will rather first come and ask them. You understand? And just believe what they see on social media. In fact, community has contributed so much, even in terms of they need some things. The community will come together and be like, this is our health center, let us do it. So the truth of the matter is that for many people, they trust people they know. Basically, before we even start going to all the other things. So the truth is, the best way to combat mistrust is really by offering people good quality services in terms of preventive and curative services, like actually being integrated into the community, making our communities be part of the health facilities. Like, for example, when we went out in December, many of the people leading the way were community leaders that were known. So when people see them, even when they are looking at you arguing, that person just looks at them and like, these are our people. And, they listen. So at the end of the day, healthcare must come back to the grassroots for it to be effective. I think that's one of the first things I will say. Then another point I want to bring out is that you have so much misinformation, miscommunication. But you see, as health sector in general, we're not actively combating it. So for every 100 TikToks you have on one word, go and bathe with salt, or go and use this or use that, people don't see an equal and opposite reaction in terms of, what our healthcare people say. You only have so many like Aproko doctors. How many are they? Very few. So that's another problem. We ourselves need to harness the power of social media for good, so that when people search, it's not just wrong information they are seeing. They are also seeing the availability of real information. Like now, what SYNLAB is doing, how many health facilities do that to actually bring healthcare out into the open spaces where people are? So for me, that's another issue. You shouldn't have to only go to the health facility or hospital to be able to engage, to talk, to get information. So the way people are, all sorts of people are on social media saying they are healthcare specialists when they are not, then we also need the healthcare specialists themselves to be on social media, people that know how to do health advocacy, health communication, to be online, so that people can easily have access to real information that is backed by data, that is backed by evidence. And then the third thing, of course, we can't say it over and over again, you need community participation. You see, when the community and the key stakeholders, religious leaders, traditional leaders, people that people respect, they need to be part of the people that are pushing the agenda of good healthcare access, that are giving people factual information. Because if people you respect are talking, if at church, like I remember in December, they would announce that, look, they're outside after service, please make sure you can take vaccination for your children. If the people you respect are showing you that they too have been vaccinated, they are vaccinating their children, then it reduces the risk and the likelihood that people are rejecting our vaccines. So I'll just stop here because I'm sure Dr. Adeniran will have things to add from all his expertise from WHO. Thank you.
Thank you. Excellently said. Dr. Adeniran, any thoughts on this?
Thank you, Dr. Adebayo. You said quite a lot of things, but let me just add to buttress most of her points that one of the major reasons why we have mistrust in the health sector is because most of these health interventions are partner-driven and not government-driven. Now, what happens when they are partner-driven? Number one, partners have their intentions. No matter the partner, no matter the private organization, they have their goal, they have their mandates, they have their targets for their funders, they have their expectations. So if what the funders want is that give 1,000 children, place 1,000 children on antiretroviral therapy, and we have given you $1,000 to do that. Even when they see these children hungry and these children need food, and this food is cheaper than the antiretroviral that they are bringing, they would rather give the children the expensive antiretroviral and deprive these children of food. So at the end of the day, people begin to ask that my child is hungry. He needs $1 to buy food. Now you are here with $1,000 antiretroviral. Now we are begging that please keep this $1,000 antiretroviral. First give us $1 food, but you cannot provide it because your funders have given you only money for only antiretroviral. So it begins to drive mistrust that how can a government that has left us in flood, in IDP camps, hungry, no shelter, no food, now come with vaccines or goods or drugs or vaccines? Can we really trust these vaccines? Because they believe that the primary needs have not been met. Now you are coming with things that we feel, well, these things are good, but you should have given us this before you bring this. But they will not understand because partners come in the name of government. When they implement, they come in the name of, okay, we are doing this on behalf of the Ministry of Health. However, they actually have their mandates. They are funded to carry out specific activities. And he who pays the piper dictates the tune. So they will focus on the activity because they have to meet their targets to impress their funders so that they can keep running the organization. So until government takes the lead and takes responsibility, because most of these interventions are partner-driven and donor-funded. So when government takes the lead and takes responsibility for those primary needs of people, then when partners come with the secondary needs, they will have that trust to accept those things. Most time when we go for health campaigns, what they ask us is that, come, we are hungry here, and you are coming with vaccines. We are suffering. Look at where we are living. No latrines, no toilets, no good water to drink. Okay, we don't have water to drink. Now you have come with drugs. Which water do we use to take these drugs? But it will be difficult for us to explain them that, well, government should provide water. We are coming with the drugs. We don't have water. So it has created a mistrust during health campaigns. So what am I saying is that government should take the lead. Government should take more responsibilities and not leave most health interventions in the hands of partners. Thank you, Dr. Adebayo, for those wonderful insights.
Thank you so very much. Thank you so very much. Quite a lot has been said here, and it's been an eye-opener. There's one last question, and it's for both of you. And I will share my thoughts even as I ask the question. There's a lot of noise and banter around health tech. And my opinion has been, for some tech innovations are quite important. There's one that I'm a huge fan of, which has to do with healthcare financing. And for me, it's an alternative to insurance for people who maybe like to save or would like to save towards their healthcare needs and still access healthcare at a discount from facilities. And there's a very innovative solution designed by a young lady, Jenny, called Clafia, which is something I'm very much appreciative of, and the impact it would have if if of course she has to spend a lot of money on health education to get people on board with it. It has to do with health savings accounts. But beyond that, you also hear of different healthcare innovations, healthcare technological innovations. But for me, my biggest problem is always that these healthcare innovations, you're building tech on an infrastructure, but the infrastructure is non-existent. So you're building technology to enable what? Because I see technology as an enabler. Okay. So when you don't have the right infrastructure, i.e., you don't have the right hospitals, and in fact, that's one of my concerns, even with telehealth. So telehealth, healthcare does not end with just talking to the patient. At some point, you need to physically visit the patient sometimes, okay, to really understand and really engage and all of that. But perhaps when it gets to that point, there's no physical infrastructure, or The physical infrastructure exists, but there are other things that are to act as enablers in that physical infrastructure that is not there. So you have the tech enablers already floating on top, but the brick and mortar infrastructure that should stand, the power, internet, all of that, road, all of that, are not yet solidly in place. How do we balance this out so that at the end of the day, we don't see frustrated tech entrepreneurs, or we don't see what's it called, tech innovations that do not really deliver on its promises? I would like to know what your thoughts are on this, quite frankly, before as we close out. What are your general thoughts around this?
Okay, thank you, Dr. Kenneth. So I think the problem is that we don't sit together before we make policies.
Mm.
A beautiful policy comes to the head of a policymaker, sits somewhere, consult few people. We don't do proper stakeholder engagement. Let me give a very small example that came to my mind. There's a governor somewhere in Southwest Nigeria doing great, doing very well. I think he partnered with there was a PPP arrangement where they are now generating about 11 megawatts of electricity in that state. Now, when he selected the infrastructure or the agencies that will benefit from this 24-hour electricity supply, he picked the major general hospital in the state. He picked neighboring schools. He picked the High Court of Justice. He picked some strategic roads with street lights. He picked the state secretariat. This is quite interesting and intelligent. That with that 11 megawatts electricity supply, he has picked the educational system, he has touched the judiciary, he has touched the health sector, he has touched the roads and the secretariats. The point I'm making is that sometimes in Nigeria, we just move into where we think we can prosper, and we do whatever we think will make us prosper. Now, we have people in the real estate that are doing great in Nigeria. How many of them are doing something around health infrastructure? We have major entrepreneurs in Nigeria that are building power plants. A major billionaire in Nigeria just concluded a 1,250 megawatt power plant. Who is speaking with that entrepreneur in terms of how that power plant will benefit the health sector? We have people in tech. They are doing great in tech. Most of them are going to finance, money transfer, and all those things. How many of them are being spoken to about how tech would benefit the health sector? So what I'm saying is that the government has not given us a platform for us to sit together. The health entrepreneur, the tech, the finance, the judiciary, the politicians, to sit together and discuss that this is what we are doing in power industry. And the health personnel speaks that, okay, this is how we can key in to what we are doing. So we don't really have a platform where we sit together and we make policy that has an integrated approach. So you just see people, very brilliant tech entrepreneurs doing great, but they are not really doing much in the health industry. But somebody is speaking to them. Somebody is telling them how their innovations will be useful in the health industry. We have real estate agents now. It's one of the thriving business in Nigeria now. And what are they doing? They're all building houses everywhere, filling houses, residential apartments. Who is talking to them about health infrastructure? Who is talking to them about road infrastructure? So everybody wants to have an idea. All that comes to your mind is, how best do I make money from this idea? Any other thing doesn't matter. So I think we also need a platform that can only be coordinated by the government, where innovations come together. Probably what we call innovation hub. Innovations come together from tech, from real estate, from medicine, and we'll begin to look at where one innovative idea feeds into the other, so that kind of situation where the tech is left floating, they have the idea, but they don't know how it fits into the health system, does not occur. My thoughts. Thank you.
Thank you very much, Dr. Adeniran. Dr. Adebayo, I don't know if you have any closing remarks with regards to what I
Just to
raised.
add to, thank you, Dr. Kenneth. Dr. Adeniran, I think you said it all. It just reminded me of a little story that one of the MDs of a general hospital, she's a friend and a colleague, and she was just telling me, she resumed at the hospital, found out that, they were supposed to do CCTV and all that, but it hadn't worked. And she said she just looked at solar panels lying down there, not working. And that's how she called engineers. Can we use this for our maternity center so that they have lights? You understand? So that there's 24/7 light there and all that. And she was able to repurpose the solar panels that came for
Mm,
CCTV since they weren't able to do that project anymore. And
mm,
now it's working for the maternity center. So many times we have to like what he said is it we have to stay together even at the planning stage is
mm,
know where you get our gaps are, and I think we
mm,
always need to start from first principles to
mm,
address basic problems before we even move on to the next. Like for example, now we talk a lot about electronic data collection, even when we're using our data tools, even for most of the supervision we're doing. And I think one of the key things that we have realized that we need to have things that can work offline. For example, I'll mention Avada that was used by WHO, which our community informants use, to notify of, priority diseases. They built it on a USSD system. And
mm,
so whether they have data or not, and it's simple enough for someone with a basic education, to use. And after
mm,
that, the verification level is now more complicated and done at a higher level. But it solves the issue of real-time data collection on disease surveillance in the community. So I think
mm,
that's what we need to do. I remember even Summers, Dr. Adeniran, Summers is a platform we use for surveillance. I remember even when we started using it, we had to give them feedback about how difficult it was for people that are just on the field that need to move fast. And so
mm,
they evolved to develop it in a way that front end is easy for any surveillance officer to use. So I think, even when we're thinking health tech, we have to sit down with the people that are going to use with our technology so that we make sure that we are meeting the needs.
mm.
The issue of infrastructure is multi-sectoral.
Yeah.
It's very multi-sectoral, and it's
Mm,
not what's this? It's very multi-sectoral, and it's not something that everybody can do.
mm. Hello, Dr. Adebayo, are you there?
Sorry.
Okay. Hello, ma'am. Oops, I hope we've not lost her. Hello. Okay. Well, I think that the key point she raised is the fact that it's important that whenever we are designing anything, either in tech, either in anything at all, it's important we have sufficient stakeholders in the planning stage. If we don't have this, it makes things quite difficult at the end of the day, or at the end of the day, you end up producing things that people may not need or may not really speak to the problems that are um immediate. Okay. And of course that distorts the balance between demand and supply, because the demand is saying I want this, supply is producing this, and then at the end of the day you don't get returns. The consumer gets frustrated, the entrepreneur gets frustrated. So it's important there's an alignment, and it's important there's a lot of um, data collection. There's a lot of research done at the initial step. It takes a lot of work, but I believe it pays off at the end of the day. Thank you very much, Dr. Adeniyi. Thank you very much, Dr. Adebayo. It's been quite an interesting conversation. Um, we would tease out the main points from this meeting. And of course, as we usually do, we would share this with relevant policymakers and also publish it so that the public understands some things that are being done and suggestions that have been raised. It's our it would be a huge delight if some policymakers are able to pick this up and run with it. We would play our own part to try to show it to them, as we often do. And the goal at the end of the day is that this is not just a talk shop, but that we're able to drive important, tangible transformations from these conversations, and that of course ultimately elevates the healthcare industry in Nigeria. Having said that, thank you very much, and I hope when we call you guys again sometime soon, we would have the grand privilege of having you honor our invite. Thank you so much, and we look forward to hosting you again some other time. And to our guests, want to say thank you, and once more apologize